Hello guys, Assalamu alaikum. My name is Dr. Faraz Ahmed and today I am back with a new podcast, and in this podcast we are going to cover about the endocrine, important questions and the MCQs points that can come in your PLAB 1 or MSRA exam will be discussed in today's podcast. So the first topic from the endocrinology is the acromegaly. Everyone knows it is very easy to diagnose the acromegaly case. Most of the time acromegaly, which is the excess of the growth hormone, happens because of the pituitary adenoma. So clinical features, let me repeat for you. There is a spade like hand, like the enlargement or the beginning of the hand, and the enlargement of the nose or the jaw. Lower jaw is enlarged, tongue is also enlarged, and most of the time what can happen, patient can present with a bitemporal hemianopia as well. Okay, so the important thing which you have to keep in your mind for the MCQs point of view is what is the initial or the screening test. Please keep in mind this is initial or the screening test, that is insulin like growth factor 1, and the most definitive important or the confirmatory test is oral glucose tolerance test with the serial glucose measurements. So this is the important thing, and what you have to do, you have to keep these 3 points in mind, like acromegaly, and you have to keep in the acromegaly insulin like growth factor and the oral glucose tolerance test with the growth hormone measurement repeatedly. So how glucose tolerance test can differentiate like this is acromegaly or this is diabetes mellitus. So please keep in mind, in normal people growth hormone will do what, it will suppress the glucose, and in acromegaly growth hormone is unable to suppress the glucose production. So next topic is hyperprolactinemia. In hyperprolactinemia, what happen, like there is milk discharge in the non-pregnant woman and there will be the amenorrhea. You have to keep two things in your mind. Number one is the amenorrhea and number two is the galacturia, that is the milk production in non-pregnant ladies. Non-pregnant ladies, milk production and amenorrhea. Think about the hyperprolactinemia, and most of the time this is happening because of the pituitary adenoma, so definitely patient will be complaining of the bitemporal hemianopia. So this question can come as a diagnosis. So let's talk about the thyrotoxicosis management during the pregnancy. Please keep in mind, normally in all the female we use carbimazole, and what will happen during the pregnancy. So please keep in mind, preconception, before the pregnancy, in the first trimester and after the pregnancy. Please keep in mind, preconception, first trimester of the pregnancy and postpartum we are going to use propyl thiouracil, and during the second and third trimester of the pregnancy and in general population most of the time we use carbimazole. And the other important thing is that during the pregnancy whatever drug you are going to give, either propyl thiouracil in the preconception stage in the first trimester or postpartum, or carbimazole in second or third trimester, what you have to do, you have to give lowest possible dose. Okay, and please keep in mind, radioiodine is contraindicated during the pregnancy whatever the trimester is. And important thing, if your symptoms are not gonna control with carbimazole or the propyl thiouracil and you have to do surgery, so you can do partial thyroidectomy in, not in the first trimester, not in the third trimester, you can do thyroidectomy in the second trimester. Everyone knows diabetic ketoacidosis happen in the type 1 diabetes mellitus, and presentation, everyone is aware about the presentation. Basically patient present with the abdominal pain, vomiting, and patient present with a deep hyperventilation, you can call casmol breathing, dehydration, glucose could be more than 10, more than 11 or the 12. So what you have to do, management is important. Everyone know, don't tick on the insulin. First of all, you have to click initially on the IV fluid, then IV infusion of the insulin, and then you have to do the ABGs. Okay, please keep in mind, you have to keep measuring the capillary blood glucose repeatedly in the management of the diabetic ketoacidosis. Let me repeat again for you. You must be aware about this in the cardiology section. Hyperkalemia. If there are the ECG changes, what would be the ECG changes in the hyperkalemia? Tall tented T waves, prolonged QRS complex. So what you have to do? You have to first of all protect the heart by giving the IV calcium gluconate or the calcium chloride. Once you have protected the heart, then what you will do? Then you will lower down the potassium. And how you have to lower down the potassium? You can give insulin with the dextrose, or you can give the salbutamol nebulization. So please keep in mind, in the hyperkalemia, first protect your heart, then lower down the potassium. So please keep in mind, prostate cancer in the men and the breast cancer in the female are the most common cancer that spread to the bone. Prostate cancer, breast cancer are the most common cancer that metastasize to the bone. So what happens when these cancer metastasize to the bone? Patient present with the hypercalcemia. And what are the features of the hypercalcemia? So please keep in mind, hypercalcemia features are most of the time related to same features as the type 1 diabetes, like polyuria, polydipsia, patient present with confusion, depression, low mood. There could be the stone because of the hypercalcemia, could be abdomen, and constipation is very important. Type 1 diabetes symptoms, confusion and constipation, if you keep in your mind, and these are the features of the hypercalcemia. So if someone is having the prostate cancer and that patient is presenting with these features which I have just mentioned, so what test you have to do? First of all, do serum calcium, and if serum calcium is raised, it's confirmed this is hypercalcemia. You have to do management. So initially what you have to do, because there is a lot of calcium in the blood, you have to rehydrate with the IV fluid. And once you have rehydrated the patient, and then what is the definitive management? That is bisphosphonate, include alendronate, resindronate, or the pamidronate. So you can give any of these things. These are the bisphosphonate, which is the definitive management of the hypercalcemia. So let's talk about the management of the hypoglycemia. First of all, most of the time in the hospital, patient present with the loss of consciousness, and first of all, what you do, you take blood pressure, and after taking the blood pressure, you do BM, that is your blood glucose, and most of the time the blood glucose is low. So if blood glucose is low, that's mean hypoglycemia is confirmed. So you have to manage the patient as per the status of the patient. If patient is conscious and can swallow, what you have to do, you can give what? You can give the glucose jelly, you can give the dextrose gel to the patient, or you can give the 200 ml of the fruit juice. But if patient is conscious and cannot swallow, what you have to do, you can give 200 ml of the 10% glucose IV, or you can give 1 milligram of the glucagon IM as injection. But if patient is unconscious, this is important. Keep in mind, if patient is unconscious, you have to give IV 75 ml of the 20% glucose. So please keep in mind, cortisol is basically called as a stress hormone. Any type of stress to the body, including the surgery or any other stress. So surgery is basically a stress to the body as well. So body increases concentration of the cortisol, and that leads to the hyperglycemia, and that hyperglycemia is called as a stress hyperglycemia. You have to keep two associations of the lung cancer related to the endocrine problem in your mind. So that there are two types of the basically lung cancer that are related to endocrine issues. One is the small cell lung carcinoma, and the other one is the squamous cell carcinoma. Please keep in mind, squamous cell carcinoma is associated with hypercalcemia. Hypercalcemia associated with squamous cell carcinoma of the lung, and the small cell carcinoma of the lung, it is associated with Cushing disease, Cushing syndrome, and SIADH, syndrome of the inappropriate ADH secretion, that is hyponatremia. So sometimes MCQs can come like hyponatremia is associated with small cell cancer of the lung. Let's talk about the type 2 diabetes mellitus management in an obese patient with the chronic kidney disease. Obese patient with chronic kidney disease is coming to you. How you will manage the diabetes? So there are two options. You can start the patient on the insulin, or you can start the patient on the gliptin drugs. So apart from this, why we can't give the bigonoids or the metformin? You must be aware of this. Like if EGFR is less than 30, we can't give metformin to the patient. And the other important thing is that sulfonylureas, that is gliclazide or other drugs, they are also contraindicated in the renal impairment. So keep in mind, metformin and sulfonylureas are contraindicated in the renal impairment, and this patient is obese. We can't give glitazone to this patient as well, because they causes the increase in the weight. So we can't give any other thing to that patient apart from the insulin and the gliptin. So if someone is obese with renal failure and he is type 2 diabetes mellitus patient, what you have to do, give insulin or gliptin to that patient. Next important topic in the endocrinology is the pheochromocytoma. Please keep in mind pheochromocytoma is very rare adrenal tumor, and this tumor basically secrete catecholamines. That means it secrete epinephrine and norepinephrine. So key word in the pheochromocytoma is episodic. There may be episodic headache, there may be episodic hypertension that is not treated with the regular medication. Episodic headache, episodic hypertension, sweating, tremor, palpitation, anxiety. So please keep in mind episodic is a key feature in the pheochromocytoma. So if patient is presenting with these features, so what you have to do, so initial diagnosis is 24-hour collection of the metanephrines. Please keep in mind this test is not collection, this is not a collection of the catecholamine, this is 24-hour collection of the metanephrine. But unfortunately if metanephrine is not in the option, then you can click on the catecholamine. So what you have to do to confirm the diagnosis, so you have done the 24-hour collection of the metanephrines and they are raised. So how you will confirm the diagnosis? With MRI of your kidneys. Okay, so what is the treatment? So definitive treatment of pheochromocytoma is the surgical resection of the tumor. So if patient is hypertensive, patient is not responding to the normal medication or the regular medication of the blood pressure, you are going for the surgery. Before the surgery, how you will control the blood pressure of the patient? Please keep in mind to control the blood pressure before 7 to 10 days of the surgery, you will start your patient on alpha blocker, that is phenoxybenzamine. So let's discuss one important MCQs. There is a patient of type 2 diabetes mellitus. You have done some testing and that showed the microalbuminuria and patient is mildly hypertensive, or sometime there could be the normal blood pressure as well, but patient is a known case of the hypercholesterolemia. Patient is already on the metformin and patient is already on the statin drugs, but patient blood test or the urine test are showing the microalbuminuria. So how you will treat or what medications you are gonna add to the patient medications? So microalbuminuria mean patient kidneys are getting deranged, kidney functions are getting deranged. So how you will protect the kidney? Definitely to protect the kidney you have to give the ACE inhibitors to your patient. So the next question is related to the management of the type 2 diabetes mellitus. Please keep in mind management basically depends upon your HbA1c value. So if your patient is coming with hyperglycemia and HbA1c is little bit deranged, okay, but it is less than 48, what you have to do, you have to give the lifestyle modification to your patient. But if HbA1c is more than 48 but less than 58, what you have to do, you have to add one drug, that is metformin. But unfortunately patient is presenting again and this time the HbA1c is more than 58, what you are gonna do, you are gonna add the second hypoglycemic drug. Okay, let me repeat for you. If HbA1c is less than 48 but more than 42, lifestyle modification. HbA1c is between 48 to 58, one drug, that is metformin. If HbA1c is more than 58, add another drug with the metformin. So let me give you another important MCQs. There is a patient of the uncontrolled diabetes mellitus. EGFR is less than 30 and patient is a known case of heart failure and patient BMI is 35. How you are gonna treat this patient? What is the best option? As I told you previously, so the only best option in this patient is insulin. You can't give metformin because EGFR is less than 30. You can't give sulfonylureas because patient is obese. You can't give sitagliptin or other gliptins to that patient because he is having heart failure over here as well, and you can't give glitazone, patient is already obese. So the only option is insulin. So let's talk about the important topic, that is Addison's disease. Basically, Addison disease is primary adrenal insufficiency. Adrenal insufficiency means there is deficiency of cortisol and aldosterone. Both hormones are deficient in the Addison disease. So what happened during the adrenal insufficiency in the Addison disease? There is some problem with the adrenal glands that are not producing the cortisol and the aldosterone in the enough amount, but your pituitary is sending enough ACTH, is adrenocorticotropic hormone, to stimulate the kidneys. So because of this, cortisol, aldosterone are less, but ACTH is very high. So what will happen? What will be the features? Feature will depends upon the high ACTH and low cortisol and the aldosterone. So ACTH is high. What will happen because of the high amount of the ACTH? Hyperpigmentation of the skin will happen, and because of the low aldosterone, what will happen? Electrolyte imbalance will happen. It will lead to hyponatremia and the hyperkalemia. Keep in mind hyperkalemia in the Addison disease, and because of the low cortisol, what will happen? Patient will have hypoglycemia and the postural hypotension. So hyponatremia, hyperkalemia, postural hypotension and hypoglycemia with hyperpigmentation of the skin are the features of the primary adrenal insufficiency. And the Addison disease is basically most of the time happen because of the autoimmune problem. This is autoimmune disease, but sometimes TB infection can also lead to the Addison disease as well. So to diagnose this disease, you have to do only one test, that is ACTH stimulation test. You can also call this test as the short synectin test as well. So please keep in mind, this is very important for your MCQ's point of view. So as I told you, there is deficiency of the cortisol, there is deficiency of the aldosterone. You have to manage this patient with the supplementation of these hormones. You can give the glucocorticoid and the mineralocorticoid, and please keep in mind hydrocortisone you have to give, usually given in the 2 or the 3 doses. Patient typically require 20 to 30 milligram of the hydrocortisone every day, and most of the time hydrocortisone is given in the morning. Apart from hydrocortisone, you can give the fludrocortisone to that patient as well. So let's talk about the Addisonian crisis, or what is the adrenal crisis. So basically there is a patient who is known to have the Addison disease, and unfortunately, as I told you, what is stress hormone? Cortisol is basically a stress hormone, and a known case of the Addison disease, and that patient has some stress. What could be the stress? This could be some operation, this could be some infection, this could be sepsis, this could be dehydration. If any of these stress are going to affect a patient of the Addison disease, so that patient can go in a sudden deficiency of the hormones. Which hormone? Cortisol and the aldosterone. So the difference between the Addison disease and the Addisonian crisis is that the Addison disease features develop over a couple of the time, over a period of time, but the Addisonian crisis happens within few days, or you can say within hours as well. So because of the deficiency of the same hormone, cortisol and the aldosterone, the feature will stay same, that is hyperkalemia, hyponatremia, hypoglycemia and the metabolic acidosis. Along with these typical features, there will be the features of the cause of this Addisonian crisis. There could be feature of sepsis, there could be feature of dehydration, there could be feature of the surgery, like this could be the post-operation, post-surgery as well. So what you have to do, you have to manage this patient very well. So first of all, what is gonna happen? Patient will be dehydrated and patient will be hypoglycemic as well. So you have to give this patient normal saline, and you can give the dextrose as well. Apart from this, you will give the hydrocortisone, fludrocortisone, as I told you previously. So this could be life threatening. Please keep in mind the management of the Addisonian crisis is very critical. So we have discussed about the deficiency of the cortisol and the aldosterone, and that is your Addison disease. Now let's talk about what happens if the aldosterone is increased or the cortisol is increased. So if there is hyperaldosteronism, that condition is called as the Conn syndrome, and if there is increase in the amount of the cortisol, what happens? Cushing disease will happen. So let's talk about the Conn syndrome first. So the Conn syndrome is basically hyperaldosteronism. Please keep in mind, in the Addison disease there was hyperkalemia and the hypotension, but the opposite will happen in the hyperaldosteronism, like patient will have hypokalemia and the hypertension. So hypertension can happen in the Cushing as well, but there will be the other features of the Cushing I will shortly discuss. But keep in mind, the hypertension in the Conn disease is very lethal. It is refractory to the normal medication like the Pheochromocytoma. So refractory hypertension and the hypokalemia, you have to think about the Conn Conn syndrome or the Conn disease. And what you will do, first of all, what investigation you will do to diagnose the Conn disease or the Conn syndrome? You have to do the plasma aldosterone renin ratio. Initial test plasma aldosterone and renin ratio, and to confirm the diagnosis, high resolution CT of the abdomen and the adrenals would be ordered or the preferred. Once the diagnosis is confirmed, how you are gonna treat the Conn disease? Because in the Conn disease aldosterone is high, so you have to give the antagonist of the aldosterone, and that is spironolactone initially. And the definitive definitive treatment is basically surgery, that is adrenalectomy. Till now we have discussed three things. Let me repeat it for you. Pheochromocytoma is basically episodic palpitation, hypertension, headache, and I told you about the palpitation and the flushing as well. Pheochromocytoma. And then we discuss about the Addison disease. That is low cortisol, low aldosterone. Features could be hyperkalemia, hypotension, and hypoglycemia. But in the Conn disease, aldosterone is high. Feature could be hypocalcemia and refractory hypertension. And what you have to do, you have to treat it with the aldosterone antagonist, that is spironolactone. Definitive treatment is adrenalectomy. Let's talk about the important point. There is a patient with type 1 diabetes. The other patient is with type 2 diabetes. They are going for a surgery. One patient is going for the minor surgery. The other one is going for the major surgery. How we will manage their diabetes? So let's talk about the type 2 diabetes mellitus first. If some type 2 diabetes mellitus patient is going for a minor surgery because they are taking tablets, and what can happen with the tablet, the risk of the hypoglycemia is very low. So if type 2 diabetic patient going for the minor surgery, you have to continue with the treatment. There is no need to do any change in the treatment. But if type 2 diabetic patient is going for a major surgery, you have to skip the hypoglycemic drugs the night before surgery. Keep in mind, stop hypoglycemic drug the night before surgery. On the other hand, the type 1 diabetes patient who is on the insulin, and if that patient is going for a minor surgery, what you have to do, you have to do a minor change. What is that? You have to omit the insulin on the day of surgery. Like if some type 1 diabetic patient is going to have a minor surgery like the removal of the lipoma at 10 a.m. in the morning, you have to skip the morning dose of the insulin. But if the type 1 diabetic patient is going for a major surgery, you have to put that patient on the sliding scale of the insulin. Let me tell you few values of the type 1 diabetes or the type 2 diabetes mellitus related to the fasting blood glucose and the HbA1c. So pre-diabetic patient, what is meant by pre-diabetic? They will have the impaired glucose tolerance test. So what will happen during the fasting hours? The blood sugar will be in the pre-diabetic patient from 5.5 to 6.9, and if it is above the 7, what does it mean? This is impaired blood glucose and patient is a known case of the diabetes. And if 2 hours postprandial, that is oral glucose tolerance test, is 7.8 to 11, if it's more than 11 after 2 hours, definitely diagnosed with diabetes mellitus. And the HbA1c in the pre-diabetic patient normal is less than 42, and pre-diabetic patient, as I told you previously, 42 to 47, and if above 48, then what you have to do, you have to start on the one hypoglycemic drug, that is metformin. So the next important topic is basically Cushing disease. What happened in the Cushing disease? There is the increment, there is excess of the cortisol levels in the blood. So because of the excess cortisol level, cortisol is basically a stress hormone. As I told you previously, what cortisol is going to do, it is going to do the hyperglycemia, and apart from the hyperglycemia, it can cause hypokalemia and it can cause the hypertension as well. But the hypertension is basically a major feature of the Conn disease as compared to Cushing disease. So what happened in the Cushing disease? Hypertension could happen, but the other features are very important. Let me tell you those features. So apart from the hypertension and apart from the hyperglycemia, patient could have the truncal obesity, and apart from the truncal obesity, patient could have moon faces, stria on the tummy, cardiac hypertrophy. Patient can develop osteoporosis because of the excess of the cortisol hormone. Patient can get weight and proximal muscle weakness. Muscle weakness could be related to potassium hypokalemia as well, easy bruising and the liability to the infection, and apart from this, hypokalemia and the hypernatremia. So these are the features of the Cushing syndrome, or the Cushing disease. So what you have to do, which investigations you have to do in the Cushing disease? So first of all, the initial investigation for the screening is 24-hour urinary free cortisol. Initial screening test is 24-hour urinary free cortisol. The best initial test to establish the diagnosis is overnight dexamethasone suppression test, and to localize the lesion where is problem. Either there is problem to the pituitary, or there is some ectopic production of the cortisol. What you have to do, you have to do high dose dexamethasone suppression test. Screening test is 24-hour urinary free cortisol. Initial test to establish the diagnosis is overnight dexamethasone suppression test, and to localize the lesion you have to do the high dose dexamethasone suppression test. So the next important topic is thyroid storm. It is similar to Addisonian crisis. That crisis of the Addison disease happened during the stress, during the sepsis, during infection, during dehydration. So same happen if some patient is known to have thyrotoxicosis or the hyperthyroidism, and patient is going to develop chest infection, patient is going to develop any sepsis, patient is going to develop any dehydration. What can happen? The features of the hyperthyroidism can develop within few hours or the few days. Like patient can present with the palpitation, tremor, tachycardia, and feeling of the warm or the fever as well. But along with this, these are the features of the hyperthyroidism. Along with this, patient will be having the features of the cause. Patient could have cause of the infection. Patient will be having the features of infection. That could be chest infection, that could be tummy infection or urinary tract infection. Patient will be having some other features as well. Please keep in mind, in thyroid crisis or the thyroid storm, because of the palpitation, they can go in the atrial fibrillation as well. So the atrial fibrillation risk is very high in the thyroid storm. And what you are gonna do for this type of patient, you are gonna treat the patient with beta blocker, propranolol, and sometime you have to give that drug IV as well. And apart from controlling the heart rate, what you have to do, you have to treat the cause. Either it's an infection, you have to give antibiotic. If this is dehydration, you have to give the IV fluid to that patient. So let me tell you 3 important points. You have to keep these points in your mind. These MCQs can come. Most of the time you can have at least one MCQs out of these 3 points. So if your calcium and phosphate are normal and ALP is also normal, all 3, calcium, phosphate, ALP is normal, that is osteoporosis. If calcium, phosphate are normal but only ALP is high, solitary increase in the ALP is related to Paget disease. If calcium is low, phosphate is low, and ALP is high, that means osteomalacia. So the next topic is very simple. Everyone is aware, like what is diabetes insipidus? This is basically production of the lot of urine. If you are producing a lot of urine, what will happen? The osmolarity of the urine will also decrease. Like you are producing dilute urine, osmolarity is decreased. So there could be central or the cranial cause of the diabetes insipidus, or there could be the nephrogenic cause as well. So how you will confirm either this is nephrogenic cause or the cranial cause? So what you have to do, you have to give vasopressin to that patient, and after giving the vasopressin you will check the osmolality of your urine. So if after giving the vasopressin there is increase in the osmolality, what does it mean? like there is decreased production of the vasopressin. So if there is increase in the osmolality of the urine after giving the vasopressin, it's mean the cause is the cranial, there is central cause. But if after giving the vasopressin there is no increase in the urine osmolality, what does it mean? It's mean vasopressin is coming from above and you have given the vasopressin as well, but kidneys are not sensitive to the vasopressin, and here the cause of your diabetes insipidus is nephrogenic. So let's talk about the next important topic, that is basically hypokalemia. Hypokalemia can happen because of the excessive vomiting, chronic alcoholism, and Cushing or the Conn disease. It can happen because of the renal issues as well. Okay, so what will be the features of the hypokalemia? Please keep in mind, because of the hypokalemia, because of the low potassium, muscle cramps, leg cramps, weakness, tiredness is very common, and ECG can show you the U wave on the ECG. So how you will manage the management of the hypokalemia depends upon the blood results. So let's revise the things. Now I am going to tell you few words, and after the telling you the few words I will let you know about the answer as well. So let's start. So our first question is, the most important treatment for the congenital adrenal hyperplasia is fludrocortisone. If the features of the Cushing syndrome, if the features of the Cushing disease decrease with the stoppage of the alcohol, this is called as the pseudo Cushing syndrome. What is meant, or what is Waterhouse-Friderichsen syndrome? So if there is adrenocortical insufficiency, either because of the adrenal bleed, because of the DIC or the meningococcal infection, this is called as the Waterhouse-Friderichsen syndrome. Treatment of the hypercalcemia, as I told you, is bisphosphonate. So treatment of the hypercalcemia is bisphosphonate. As I told you, for the screening of the diabetes mellitus, we use HbA1c, but in HIV patients, we don't use HbA1c to screen for the type 1 or the type 2 diabetes mellitus. Please keep in mind, if your T4 is normal, TSH is raised, but no antibody is positive, what you have to do, you have to repeat the thyroid function test in the 3-month time. So for the Cushing disease, initial screening test was 24-hour urinary free cortisol, and to diagnose the patient problem was overnight dexamethasone suppression test, and to localize the lesion was high dose dexamethasone suppression test. In diabetes insipidus, as I have told you, if after giving the vasopressin or after giving the ADH, if urine osmolality is gonna be more than 800, what does it mean? It's mean that was neurogenic or the cranial diabetes insipidus. But if there is no change in the osmolality after giving the vasopressin or the ADH, that is nephrogenic diabetes insipidus. And nephrogenic diabetes insipidus is basically insensitivity of the kidney to vasopressin or the ADH. So most common cause of the hypercalcemia is basically primary hyperparathyroidism. So if only ALP is high, calcium phosphate are normal, that is Paget disease, as I told you previously. If calcium and phosphate are low, ALP is high, that is osteomalacia. The other important thing is that if your TSH is normal, T4 is lower the value of the normal limit, and T3 is also the lower value of the normal limit. TSH is normal, T4 and T3 are lower the value of limit. This is called as the sick euthyroid syndrome. A young routine test, only bilirubin is high. A young patient on the routine test, only bilirubin is high, and this is Gilbert syndrome. So if sodium is 114, like this is hyponatremia, and you can suspect small cell carcinoma of the lung or the syndrome of inappropriate ADH secretion. So if there is solitary nodule of thyroid, what you have to do? You have to do the ultrasound of your thyroid. So in which conditions skin pigmentations happen? As I told you, in Addison disease, skin pigmentation happen because of the excess ACTH production. Another important MCQs is, what is the commonest cause of the SIADH? The commonest cause of the SIADH, that is idiopathic. So commonly this is idiopathic, and the most important treatment what you have to do in the SIADH is fluid restriction. So let's quickly talk about the three types of the cancer of the thyroid, which normally come in your exam as a MCQ. So anaplastic thyroid carcinoma. So basically the features are related to the spread. This is anaphylactic. So, okay, and sorry, anaplastic thyroid carcinoma. So features are evident from the name. So features are due to spread, maybe dysphagia, maybe hoarseness of the voice, there could be dyspnea, and the large hard mass in the thyroid and the cervical lymph node may be high. So the second important carcinoma of the thyroid is medullary thyroid carcinoma. So please keep in mind, in the medullary parafollicular cells are there, diarrhea, flushing, and the increased calcitonin levels. So the papillary carcinoma of the thyroid, there will be history of the thyroid irradiation or the irradiation to the neck, or there will be the history of some radiation exposure to the neck. That cancer will be papillary thyroid carcinoma. So let's talk about important syndrome that is called as the Sheehan syndrome. Postpartum, decrease in the functioning or the hormones from the pituitary that lead to Sheehan syndrome. Because what happen if there is excessive bleed in during the delivery, that is called what happened due to excessive bleed during the during the delivery, it will affect the pituitary, and because of the hypoperfusion of the pituitary will stop functioning normally, and because of the less hormones from the pituitary, patient will develop no breast feed, or patient will develop amenorrhea. So postpartum, excessive bleed during the delivery, and there is no feed to feed the kid, or patient is complaining of the amenorrhea, this is Sheehan syndrome. So no breastfeeding, amenorrhea is related to Sheehan syndrome after the pregnancy. So last important point related to grave disease, basically this is type of the hyperthyroidism, and the incident is not similar in the men and the women. So most of the time grave disease happen in the women.